I'm sorry. I'm sorry for any trouble. Dear Professor Baldoncini and Maldonado and Benes and Imad and Nair, thank you for your kind invitation. It's really a great pleasure for me to join you in this special webinar and to share my experience. And I'm very happy to be here with such a distinguished faculty. Especially Pablo Gonzalez Lopez. I'm very proud of him, what he is doing, and I really enjoy his talk, and I'm very happy to meet with him. My talk about the selective amygdalohippocampectomy for mediobasal temporal epilepsy. First of all, I like to mention, instead of using mesial, I prefer to use mediobasal temporal. I think the term of mesial is wrong to use here, because mesial means the inner side of the teeth. So no relation with the hippocampus or limbic lobe. So the correct term has to be mediobasal temporal region. Just to clarify the terminology. I don't want to talk too much with the history, but the epilepsy is the very old. There are many information about epilepsy in the history. One of the first one is from almost 4,000 years ago, from the Code of Hammurabi. In the Code of Hammurabi, he mentioned that a slave just bought to appearing to suffer from the epilepsy attack can be returned to the seller. So you cannot sell epileptic slave in the Hammurabi Code. And also one of the first earliest recorded tablets, also in Babylonian period. But of course, they mentioned that this epilepsy has a supernatural origin related to moon goddess or Ishtar or Ianna, or of course, they thought that this is related to God. Of course, the first time the Hippocrates mentioned that the epilepsy is a natural disease and it's coming from brain. This is very important development on the history of medicine, of course. And then this is interesting picture. This is from 12th century. It is British Museum. The Epilepticus sic curabatur, the way to cure epilepsy. This is the first intraoperative drawing of epilepsy surgery. And they were curing epilepsy with trepanation and cauterization. Just 200 years later, also Turkish physician Şerafettin Sabuncuoğlu, in his book, draw also the surgical technique for curing epilepsy. This is, I think, the second drawing about the epilepsy surgery. Of course, without mentioning Horsley in London, we cannot talk about epilepsy. He did the first epilepsy surgery with Jackson. Of course, Krause from Germany, Forster from Germany. They were the first epilepsy surgeons. And then, of course, Penfield from Canada described the temporal lobectomy for temporal epilepsy surgery, which temporal lobectomy is still one of the most common surgical technique for treatment of mediobasal temporal epilepsy. And it is one of the most successful surgery also. And he described to remove the 2/3 of the temporal lobe, and then with also hippocampus and amygdala. It must be difficult without hippocampus and amygdala, of course. We are coming to selective amygdalohippocampectomy because with the electrophysiologist studies, the most of the mediovasal temporal epilepsies originates from amygdala and hippocampus. So the great idea came from Niemeyer, from Brazil, that why we are taking whole temporal lobe if the problem is in the amygdala and hippocampus, why we are taking whole temporal lobe? So we have to take out the hippocampus and amygdala selectively. Imagine without microscope. He described this approach in 1958 go through the middle temporal gyrus to reach the ventricle and then to remove the amygdala and hippocampus. And this was the great development of in epilepsy surgery. And then 1982, Professor Yaşargil, my mentor, described selective amygdalohippocampectomy via pteronal transsylvian approach. He got this idea when he removed the craniopharyngioma or other tumors, and he when opened the sylvian fissure, he found out that amygdala is in front of him and the hippocampus is just there. Why not to take out? Originally, as you know, he was not an epilepsy surgeon. He was a vascular surgeon and tumor surgeon. And then in his department, there were an epilepsy surgeon. But he was doing temporal lobectomy. So he got the idea to remove the only amygdala and hippocampus via transsylvian approach, because he was using transsylvian approach for almost every day. And he described this approach in 1982, which one of the topic I would like to talk about. The key point is the opening the sylvian fissure very well, and then through the inferior perinsular sulcus, you can reach the ventricle. Of course, this artistic drawing exaggerates the anatomy, but normally in the surgery, only surgeon can see something because we are working in very small area. But the drawing describes better. So to get the vascularization of the hippocampus, the understanding of the vascularization of the hippocampus and amygdala and the surrounding neural structure is the key point, of course. And in the anterior part, the amygdala is removed, and then he removed the hippocampus after amygdala. So the opening of the sylvian fissure is the key in the success of this approach without damaging neocortical structures, including temporal pole. And then first removal of amygdala and uncus, and then opening the pia and identification of the internal carotid, posterior communicating, anterior choroidal, posterior cerebral artery, basal vein, third nerve, optic tract. These are because the hippocampus itself is not eloquent structure, but everything is around the hippocampus is totally eloquent. So it's more difficult to get there. And then opening the choroidal fissure through the tenia fimbria, between fimbria and choroid plexus, and then the transverse section of the through the tail of the hippocampus, and then lateral incision the hippocampus through the collateral eminence. These are his descriptions, and it's beautifully illustrated, and it is very nice surgery, very well described surgery. He used this for selective amygdalohippocampectomy. No, there are still discussion that, with temporal lobectomy, we have the same seizure control. Why we are struggling to remove amygdala and hippocampus in very difficult surgery. The selective amygdalohippocampectomy is not an easy surgery. But still, many people, many experts also describe another techniques for selective amygdalohippocampectomy also in the same time. Professor Spencer, 84, he described anterolateral resection to get the hippocampus and amygdala. It's also another beautiful technique. And then Dr. Kelly described magnetic resonance imaging-based computer-assisted stereotactic resection. Interesting, Dr. Shimizu, this is also a good idea to cut the zygoma and then to get the mediobasal temporal region. So these are another techniques that how we can get the mediobasal temporal region, because with the development of the neurophysiological studies and development with MRI, now we have better indications for selective hippocampectomy. This is another technique. And then Dr. Hori described subtemporal amygdalohippocampectomy. And then Dr. Park also. But of course, these are not pure selective. Actually, Transylvian is also not pure selective, because you have to take a little the anterior part. And then, interestingly, gamma knife surgery also described for the as a selective hippocampectomy. And then inferior temporal sulcus approach is another way. And then laser amygdalohippocampectomy also described for this selective technique. And Dr. Schwartz shows also beautifully that this is also another option. Finally, this is left side of the hemispheres. I can summarize that. Many people try to describe the best technique to get the selective removal of the amygdala in hippocampus. Anterior one, Professor Yaşargil described Transylvian approach, and Dr. Spencer described anterolateral temporal approach. They both are anterior view to get the hippocampus and amygdala. And then lateral approaches, it can be lateral transcortical, it can be through the superior temporal sulcus, or middle temporal gyrus, or inferior temporal sulcus. These are similar approaches, but it is lateral transcortical approaches. Subtemporal approaches, Dr. Hori described subtem, but you have to remove the inferior temporal gyrus and fusiform gyrus also. And also Dr. Park described transparahippocampal, he just retract. And then zygomatic, also you have to remove the inferior temporal and the fusiform gyrus to get that. But overall, the approaches can be anterior or lateral. I personally, the Professor Yaşargil is my mentor and my teacher, and I learned Transylvian approach, and I prefer to use Transylvian approach. Also, I work in the laboratory, and I find that this is the less invasive approach. Surgical approach is not easy, as I told you, with the mediobasal temporal region, because the hippocampus itself is not eloquent, but the surrounding structures are totally eloquent, the intervascular structures and the neural structures. And there are danger for neurological deficit. So you can find here many neural structures and vascular structures. If you want to deal with the hippocampus and amygdala, you have to deal with them, and you have to keep in your mind. The point is, we don't know still how much temporal lobe we have to remove, or we don't know still the functional aspects and neural connections of the temporal lobe. And so the goal should be we have to, in our procedure, depends on reduction of the amount of damage inflicted. We have to find the real target, and we have to damage only this and not surrounding structures, because we don't know the exact functional network, and we cannot monitor. If you say that the solution is awake surgery, no, because especially the non-dominant temporal lobe, the sexual function, how you can monitor sexual function or other detailed limbic functions and characters or whatever. So my goal is if you find the real sclerosis, in clear sclerosis in the 3 Tesla MRI and the all other data shows that this is the clear case, I prefer selective hippocampectomy, and I have better results. And it looks like, you know, if you have a problem in your finger, to cut the arm is not fair. So we have to find that we have to be sure, of course, the finger is the problem and we have to cut the finger. For this, I work a lot in the lab to understand this surrounding anatomy. First of all, this white matter of the temporal lobe, we have to keep in our mind. I put in 10 groups, and 8 of them we have to preserve, even in the epilepsy surgery. We have to go only alveus, fimbria, and fornix, and inferior arm of the cingulum within the parahippocampal gyrus to get the real selective amygdalohippocampectomy. Otherwise, we can damage all structures. Just I like to summarize here. First of all, of course, the cortex, neocortex. Neocortex, damage in the neocortex may create another target, another reason for the epilepsy also. Short association fibers, U fibers, and then superior longitudinal fasciculus, inferior arm of superior longitudinal fasciculus, and then uncinate fasciculus, and then occipitofrontal fasciculus, and then of course anterior commissure. These are all deep white matter structures in the temporal lobe. And then sublenticular part of the internal capsule, temporopontine fibers and occipitopontine fibers. And another sublenticular part of the internal capsule, inferior thalamic peduncle, and then posterior thalamic peduncle. Posterior thalamic peduncle includes auditory and optic radiation. In this picture, this is not pure optic radiation. This is posterior thalamic peduncle. And all posterior thalamic peduncle have a curve, Meyer's loop, not only optic radiation, but we have to preserve these structures in our surgery. The tapetum is also another neglected white matter in the temporal lobe. Inferior longitudinal fasciculus also. So our goal is to remove the only amygdala and the alveus, fimbria, fornix, just mediobasal temporal region. And then in the parahippocampal gyrus, inferior arm of the parahippocampal gyrus, the cingulum is there. So inferior arm, and we have to remove. So our target is this inferior arm of the cingulum and amygdala, uncus, alveus, fimbria, fornix. So Transsylvian approach is the very suitable approach to get there. So of course, as I told you, the development in the MRI, we now clarify better choosing the case, because we can see the hippocampal sclerosis very well. And I hope that with 7 Tesla MRI, we will see much better. And of course, the PET scan is important, and the video EEG, and all these are important. The point is how I can remove this amygdala and hippocampus and parahippocampus selective. I call it Transsylvian transamygdalar. I do a little different than Professor Yaşargil. I go more anterior. I go directly to preform cortex. I go directly preform cortex to amygdala, and then remove the amygdala and go back. The problem in this approach, the advantage of this approach to so-called preserving temporal stem, no danger for optic radiation, uncinate, or fronto-occipital. The problem in this approach, you cannot go more posterior. That's the point. Because in each case, of course, depends on the head also. My ability to go posterior is different. Depends on the condition of the brain and how atrophic hippocampus, and then the anesthesia. So or Sylvian anatomy. These points are controlling how much I can go more posterior with Trans-Sylvian approach. The main point, as I told you, that I had to go to piriform cortex and go directly piriform cortex, go directly to amygdala, and then go posterior. This is one of the sample. Left is left always in my MRIs. This is anatomic for orientation. So this case has a 36 years history of intractable seizures, 2-3 times per week, and he took 4 anti-epileptic drugs. And left-sided clear hippocampal sclerosis, you can see here. And this is very good candidate for left-sided Trans-Sylvian selective amygdalohippocampectomy. We perform electrodes, of course, in the grid and strip electrodes, and check the EEG, and then opening Sylvian fissure. That's the point. This, when I open the dura, I can tell that how difficult surgery is waiting for me. Because if the Sylvian fissure is difficult, if the venous anatomy is difficult, if the arachnoid is very thick, so surgery is difficult. For me, the Trans-Sylvian selective amygdalohippocampectomy means opening Sylvian fissure. Because if I don't open the Sylvian fissure very well, I damage the temporal neocortex, I damage the temporal pole, and this can be the reason for not good epilepsy control, because you can create another epileptic point with this way, and preserve the all veins. So I do not coagulate any Sylvian vein, and also this, you know, the Sylvian veins can go frontal to temporal, temporal to frontal, and we should try to preserve. And go down to open the Sylvian vallecula and opening the arachnoid. Depends on the arachnoid. You know, sometimes you can open with the bipolar, sometimes you need to use knife, sometimes you need to use scissors. So, but try to preserve the venous anatomy especially, and try to not retract. I do not use retraction, rigid retraction in any part of this surgery. And when I open the Sylvian fissure, I put a strip electrode just underneath the parahippocampal gyrus. And this is very important to localize the seizure activity in the hippocampus and parahippocampal gyrus, because the grid electrode can go everywhere. So this is another step in the surgery. And then this is M1, follow the M1, and here is the piriform cortex. And we have to be careful with the temporal trunk from M1, because sometimes it can be very big. So every case is different. Every case is different. But the key point is the opening of the Sylvian fissure. And then just go directly to piriform cortex, because underneath the piriform cortex, I have amygdala. And first coagulating, and then removing the piriform cortex with CUSA and the suction. Subpial, totally subpial removal, and the low power CUSA is safe to use there. And I never seen any, you see now the uncus is now clear, uncus. You can see uncus very well. I keep the PI intact, and subpially I remove the uncus, tip of the uncus. I am totally anterior than Limen insula. I am totally anterior. Left side. and remove the also rest of the, and now subpial, I see the P2. Here is the P2, and there are branches, you know, there are branches from P2 and anterocoroidal artery to hippocampus. And I am removing residual part, and then go a little faster. And now I am getting the anterior choroidal point. This is the ventricle open. I am now reaching the anterior choroidal point. And you see there are hippocampal veins and arteries goes to the subiculum. So I coagulate them and cut. Another one, this is hippocampal artery, Uchimura artery, Uhimura or Uchimura. Japanese colleagues can correct me. Famous Japanese neurosurgeon. And then go lateral now through the collateral eminence. And then now posterior as possible. You know, this is almost between body and tail. So I go posterior to cut the tail of the hippocampus. You know, they like to have one piece for research. This is the head of the hippocampus and the, some part body of hippocampus. And then the tail of hippocampus, I try to get with the CUSA as posterior as possible. This is the point in this approach, that we have very limited angle and very limited space to go, but it can be done. And now opening the posterior part of the choroidal fissure. And again, I can suck it. And this is almost end of surgery, checking with the hemostasis. So, end of surgery, the whole neocortex should be untouched. And I like to check with the ICG to see how is venous anatomy and how is also, is there any contusion. So in the ICG, you can see very well if there is contusion. And I'm very happy to see this picture that all veins are intact, and I am totally anterior than Lyman insula. And then I remove the amygdala and hippocampus. This is the posterior post-operative picture, and you can see that left-sided selective amygdalohippocampectomy is done, and with preserving neocortical structures. Very important. Some people doesn't believe that uncinate fasciculus and fronto-occipital fasciculus is intact with this approach. When you go through the amygdala, you don't touch uncinate or famous IFOF. They call IFOF. I think it's correct one is fronto-occipital. And the visual field is, I never seen problem with the visual field with this approach. Meyer's loop is much more posterior than uncinate and fronto-occipital. And this is now seizure-free. Another case, this is now the right-sided hippocampal sclerosis. Very clear hippocampal sclerosis, right side. And very nice case for selective hippocampectomy. Now, this is the right side sylvian fissure, the more complicated venous anatomy. And we put grids and electrodes, and opening sylvian fissure is the key. Again, I mentioned slowly, slowly, but try to preserve every vein, everything as much as possible. This even small vein, nothing may happen, but it's better to preserve. And the same technique, just go to preform cortex. Now you see internal carotid is here, and the preform cortex uncus is here. So I go directly to uncus, just coagulate the pia arachnoid and go remove the amygdala. And then you see I am totally anterior than M1. This is the very important. You have to stay anterior than M1 and go lateral. And now the more now medial picture, the opening the choroidal fissure and removing head of hippocampus. And now the posterior part, I'm cutting the lateral and posterior part of the hippocampus, parahippocampal gyrus. And this is the fimbria fornix, right side. Again, to remove one piece. And the rest, I will remove with the suction and the CUSA. I try to go as, this is collateral sulcus. I try to go as posterior as possible. And then that's it. And then most of the time I prefer to check with the endoscope what is the situation, because I am working in very small gap. So it's nice to see endoscope, internal carotid is here, midbrain is here, anterior choroidal here, and this is now the posterior part. Not bad. I did very well posterior resection with, in this case. Not always possible, as I told you. This is the limitation of this approach. And this is end of surgery. All the venous anatomy is intact. The temporal pole and everything is intact. And ICG also demonstrates intact structures. This is postoperative picture, and as I told you, temporal stem is intact, and the uncinate and front occipital is intact because I stay totally anterior than M1, and normal visual field. So, what was my problem that I also use another approach to selective hippocampectomy? The point started in this kind of cases. If the lesion, if the tumor is totally in mediobasal temporal region, from preform cortex to isthmus, I cannot get this in one session. I have to do anterior resection with the transsylvian, and then the second session, I have to go posterior to remove the posterior part. There is no way to remove this tumor in one session, except if you go from neocortex, you can do it, but this is not in our discussion. So we do not recommend this. So the point started with this way. So the point started how I can get the more posterior hippocampus. So for this, sometimes we have to change our view. So you see, when we change the angle, we can see the face of the Inca when we look different. So we have to look different. So Professor Yaşargil looked different many years ago to remove the posterior parahippocampal avascular lesion using supracerebellar transtentorial approach. And then he used in one case for cavernoma. And he told me that this approach should be revitalized. You have to study this approach. This was his point. But he told this everywhere, not only me. And I had great chance to work in Little Rock in the Professor El Mefti's laboratory to study the anatomy. So the idea is, you know, from if you come from anterior, you cannot get posterior. But if you come from posterior, you may get everything, entirely. So just this could be the real selective amygdalohippocampeectomy. And how we can do this? Because the problem is 1/3 of the mediobasal temporal region is in the middle fossa. How we can get the middle fossa from posterior fossa? So this is cadaveric study from Little Rock. If we cut the whole tentorium, this is our limit in the tentorium. The anterior part is totally in middle fossa. This is cadaver, and I simulate surgery to do in the cadaver, cut the tentorium, and then I remove the amygdala and uncus in the cadaver, and I see the carotid and posterior communicating. And then when I did big resection, this is very clear approach that you can get all mediobasal temporal region. But this was the anatomic study. I didn't publish this because I had to do one surgery, then confirm that this approach is suitable or feasible. I had to wait 10 years to perform my first surgery for this approach. There were many reasons for that. During this time, Professor Yonekawa published his paper. I was really, when I see this paper in the journal, I was getting heart attack, but I was happy later because he described the only posterior region. You know, my goal was taking the entire length of the mediobasal temporal region, but Professor Yonekawa described this approach for posterior mediobasal temporal region. Also, Professor Oliveira performed this approach, and he described also, but posterior. I use this approach for entire length of the mediobasal temporal region to remove amygdala and uncus. Anyway, 10 years later, I got this patient, and I find that this is suitable case, and this is excellent case for supracerebellar transtentorial approach. And the semi-sitting position is the key on the success of this surgery. 25 degrees is enough for semi-sitting position. With 25 degrees, we do not have any problem with the air embolism. Transesophageal Doppler should be obligatory because you can see any single bubble before any problem. And then paramedian incision, supracerebellar incision. Another point is the microscope. I am very lucky that I am using Professor Yaşargil's original microscope from Zurich because it is very short, very light, no autofocus, no zoom. And I can work 10 hours in semi-sitting position in this way. So this is right-sided craniotomy. And then when we open the dura, you can see the tumor. It's hanging here. When you cut the tentorium, it's there. And this is after resection. And this is endoscopic picture. Choroid plexus, here is the atrium. And the hippocampus, parahippocampal gyrus is gone. Amygdala was here. And this is internal carotid artery. This is third nerve. And this is anterior choroidal artery. And this is posterior, fetal type of posterior communicating artery. So this is the case. Postoperatively, we remove entire length of mediobasal temporal region using this approach. And of course, there is no need for this because we don't touch them. They are in the roof of the temporal horn, and the advantage of this approach. And then I said, why not to do in hippocampus, selective hippocampectomy? Because especially this case is suitable because this is posteriorly clear posterior hippocampal sclerosis. So in this case, Transylvanian approach, maybe I cannot get it. So I use this approach for hippocampal. I start to use this approach for hippocampal sclerosis, and now is my favorite. And this is the left-sided, and this is, you can do dep electrode, and then this is after resection. Left side, tentorium is here, the amygdala was here, this is roof of the temporal horn, lateral geniculate body, cerebral peduncle, cerebellum, internal carotid here, A1 here, M1 here, tentorial hiatus here. And this is more selective resection of entire mediobasal temporal region. I removed the tail of hippocampus also with this way. And now I prefer this approach. Why I prefer? Believe or not, it is easier than Transylvanian. For me, it is easier. Transylvanian approach should be done very elegantly, not easy. And I can remove all entire hippocampus and also without touching any neocortex. And you know, the Pablo even says that he didn't remove the amygdala. Pablo, you have to remove amygdala. Amygdala is the easiest part of the surgery. This is my position when I remove amygdala. Amygdala is just front of you. The most difficult point in this surgery is the opening of tentorium. If you open the tentorium very well, your surgery is done. And the difficult part is also to remove the middle fossa part of the parahippocampal gyrus, especially in the brachycephalic heads. It's difficult to get in the microscope, so I use endoscope for this. And this is postoperative picture. I remove entire mediobasal hippocampus and without touching the temporal stem or anything. And this is postoperative. All structures are intact and visual field is intact and no seizures.
The patient is
I have no time to show this video. Is it correct? I have 9 minutes video to describe this approach, but I think no time. Doctor?
We'll grant you the 9 minutes, Professor Türe.
The patient is a 40-year-old woman who has had automotor epilepsy since the age of 16. She has had seizures.
This is typical patient with the hippocampal sclerosis.
Use the paramedian supracerebellar transtentorial approach for lesions in the entire length of the mediobasal temporal region. We also use this approach for mediobasal temporal sclerosis, which is actually a disease of the archicortex. We prefer placing the patient in the semi-sitting position. 25 degrees of head elevation is usually enough for this approach. In case of cardiac septal defect,
we have to go a little faster.
Superior craniotomy is done. First burr hole is placed above the right transverse sinus. A small incision is made in the lower corner of the craniotomy to access the cisterna magna in order to drain CSF. A silicone drain is left in the cistern for continuous drainage. The main dural incision is made about 2 cm below the transverse sinus. An advantage of the semi-sitting position is that gravity allows the cerebellum to drop downward and there is no need for retraction. We always try to preserve the tentorial bridging veins by mobilizing the veins and wrapping them with Surgicel. Deeper in the supracerebellar space, the arachnoid is dissected and the fourth nerve is identified. An L-shaped tentorial incision is made with one leg approaching the tentorial hiatus and the other reaching toward the petrous ridge. Depending on the variation of the tentorial bridging veins and venous lakes, the tentorial incision may be modified to save these structures. With this custom-made needle, it is easier to place hanging sutures on tentorial leaflets to expose the mediobasal temporal region. The middle portion of the mediobasal temporal region is exposed. A strip electrode is placed along the parahippocampal gyrus. The EEG shows the epileptiform activity of the cortex. The strip electrode is now removed and a depth electrode is placed in the hippocampus through the hole made in the posterior parahippocampal gyrus. Epileptiform activity, especially in the posterior hippocampus, is recorded. The inferior colliculus is the main landmark to start resection of the parahippocampal gyrus. This is also the posterior limit of the resection. Starting at the level of the colliculus, we coagulate and cut the surface of the parahippocampal gyrus. The subiculum is then removed subpially with gentle aspiration. The P3 segment of the posterior cerebral artery is seen. The posterior aspect of the parahippocampal gyrus is resected subpially until the ventricle is entered. At this point, the hippocampal formation aligns with the surgical corridor. The tail of the hippocampus is dissected together with the fimbria. The choroidal fissure is opened and dissection is carried out, approaching the uncus. The uncal and hippocampal arteries are coagulated and cut. The uncus is then resected subpially. The hippocampus is dissected through the collateral eminence. The hippocampus is resected in one piece to be used for research. A cotonoid is placed underneath the parahippocampal gyrus. This maneuver brings the remaining inferior part of the parahippocampal gyrus into view. This portion is then removed. The amygdala is identified by its grayish color under the ependymal layer. It is then removed subpially. After hemostasis is obtained, the surgical field is visualized with the high-definition neuroendoscope. The perforators, the anterior choroidal artery, and P2 and P3 segments of the posterior cerebral artery are seen. This is the bed of the amygdala, which is now removed to expose the internal carotid artery and its branches through the pia.
So, and then
Ascertain that.
we close it, and this is the postoperative picture. And
But she
I think I have to stop now. Just to mention that for me, you know, all of the cases almost Professor Yaşargil was behind me, and he encouraged me, and he gave the idea to do this approach, and I'm very happy that he accepted this approach. That he says that this is better approach, but it's more difficult than Transylvian. This is his comment. For me, easier. I think this is depends of the experience, because he is the Transylvian. His brain is Transylvian. So, but anyway, I now prefer this approach for hippocampal sclerosis. But if the patient has a cardiac septal defect, or if there is possibility to do temporal lobectomy, if it's not clear case, I use pteronal approach. Otherwise, I use this approach. And for me, the both approach is effective and nicely can be done. But I personally prefer this approach, because the posterior hippocampal sclerosis I can remove better. And also the removal of amygdala. I can remove almost 100% of amygdala using supracerebellar, because in Transylvian, medial side of amygdala is not clear. So we can leave 10 to 20% of amygdala we have to leave. But in this approach, you can remove the amygdala. And and I hope the young generation will accept this approach. And I would like to thank especially my mentor, Professor Yaşargil, especially to encouraging me to perform this approach. And I hope next year we can meet in our meeting in Istanbul. I hope COVID-19 will be resolved at that time. Thank you for your attention.
Congratulations, Professor Ugur Türe, for your brilliant presentations on selective amygdalohipocampectomy technique, highlighting the importance of the study of the cortical and subcortical anatomy of the brain, the preoperative studies of each individual patient to perform effective and safe procedures for our patients. For all young neurosurgeons like me, who have learned from your research, publications, and your lectures around the world, it is a great honor to have you again as a speaker in our Anatomy Committee WFNS webinar. Thanks again. And one concept that has been emphasized is preserving the arachnoid and normal pia mater during the dissection of the sylvian fissure in order to avoid possible new epilepsy focus. And I want to ask you, what is your opinion about the direct access to the most medial portion of the sylvian fissure and the temporal uncus using the supraorbital trans-eyebrow approach?
I mean, the best approach to the hippocampus and amygdala could be transorbital, if you can do it. Another,
sure.
If you can do it, the best one is transorbital. So, but eyebrow incision is, I am not very happy with it, because I am not sure that it is more cosmetic. And with eyebrow incision, you have to retract more. This is, what I saw. I'm not, this is also another way. We have to be open-minded. If you do it, I like to see. And then, as I told you, the orbital, maybe transpalpebral, go to hippocampus could be the best way. But if something happened, what you can do? How you can manage any bleeding or any problem? When you create a surgical approach, you have to be ready any problems. You have to be able to deal with any problems. This is the key. Otherwise, it can be done. Yeah.
Thank you very much, Professor Türe. Thank you very much.